Good morning, everyone. Today our topic of discussion is hypertensive crisis. So, as we know, hypertensive crisis actually acute severe elevation of systemic blood pressure with or without end organ damage is known as hypertensive crisis. So, broadly, hypertensive crisis can be divided into two types. One is hypertensive emergency, and another is hypertensive urgency. When there is a severe elevation of blood pressure, acutely elevated blood pressure, along with there is a end organ damage, then we will call it as hypertensive emergency. If without an end organ damage, then it is known as hypertensive urgency. Now, approximately 1% of poorly treated hypertensive patients progress to a crisis phase, accounting for more than 50% cases of hypertensive crisis. So, it's important in turn, we can say that 50% cases of hypertensive crisis are there is a second line and underlying causes. So, we have to rule out that too. So, why it is important? Because earlier it is around with a high mortality rate of hypertensive crisis, particularly hypertensive emergency. 1 year mortality rate was around 80% and 5 years mortality rate was around 90%, 98%. But now with the improvement of treatment and medical facility, now the mortality rate has been reduced and 10 years mortality rate of a hypertensive emergencies comes around 30%. So as I told earlier, hypertensive emergencies associated with end organ damage. So what are the end organs that can damage in hypertensive emergency? So let us start from CNS. It can be encephalopathy, acute stroke or intracranial hemorrhage. Then retinal hemorrhage, extruded and papillary edema. Then acute pulmonary, cardiogenic pulmonary edema, aortic dissection, acute myocardial infarction or ischemia, post-operative bleeding, renal failure, hematuria, proteinuria, and eclampsia. So what is hypertensive urgency? So blood pressure without end organ damage. So what is the difference between these two? One is end organ damage, definitely, and apart from that, in hypertensive urgency we can treat the patient as OPD basis with oral medication. But in hypertensive emergency, we need to present hospital admission and need IV medication. As there is end organ damage, we have to prevent the further progress of the organ damage. Now, there is a term called pseudo emergency. This is the acute rise of blood pressure attributed to a physiological trigger like pain, anxiety, hypercardia, hypoglycemia, all these things. So mainly it is due to sympathetic overactivity or catecholamine surge. Now risk factor for hypertensive emergency. So these are the risk factors like male, gender, black race, low socioeconomic status, cigarette smoking, use of OCP, tricyclic antidepressant, NSAID drugs, withdrawal from medication, particularly clonidine, cocaine abuse. But things to be noted over here among risk factors, there is a age is not a risk factor for hypertensive crisis, but age itself a risk factor for hypertension. Increasing of age is associated with hypertension, progression of hypertension. But what is seen that in hypertensive crisis, the incidence seen in peak age with 40 to 50 years of age, more than 50 years. Now comes to etiology. As I told earlier, hypertensive crisis mainly seen 50% cases due to inadequately treated chronic hypertension or those who are non-adherent to the medicine. Apart from that, there is a renal-vascular disease like renal stenosis, acute or chronic kidney disease, drug-induced, as I told earlier, collagen vascular disease, particularly scleroderma renal crisis, preeclampsia, pheochromocytoma, and obstructive sleep apnea. Symptoms mainly short. This is the incidence-wise symptom classification. Symptom like shortness of breath, present with shortness of breath 29%, chest pain, headache, altered mental status, focal neuro deficit. The most common admitting diagnosis of severe hypertension, subacute hemorrhage, acute coronary syndrome, and heart failure. So what are the signs? So blood pressure, there will be a high rise of blood pressure. Actually, it is told that in hypertensive crisis, 180 by 120, systolic blood pressure more than 180 and diastolic blood pressure is 120 is a feature of severe hypertension or hypertensive crisis. But practically, there is no cutoff level of blood pressure as such. But hypertensive urgency, we can do that level 180 by 120, but it's not hold true for hypertensive emergency. I come to it later in details. Now, severe hypertension we have to confirm by two blood pressure measurements separated by 15 to 30 minutes gap. So we have to check the blood pressure 15 to 30 minutes gap and bilateral limbs. Upper and both upper limbs is most important, bilateral upper limbs as well as lower extremity to evaluate stenosis or dissection of the aorta or blood vessels. Neurologic assessment is performed to assess the mental status and neurologic motor deficit. Neurological system is most important for a patient is hypertensive crisis because there is a dysregulation of autoregulatory system of the cerebrovascular system. So neurological assessment is crucial. So we have to look for whether any confusion, we have to look for any seizure activity or not, or any altered mental status as presence or not. Vascular system is to examination need to examine palpation of pulse and auscultation of fluids, specifically renal fluids. So, optic fundi examination signs for retinopathy including exudate, hemorrhage and papilledema. So, we have to check the fundal examination too. Diagnostic evaluation. Diagnostic evaluation for to know the cause of hypertensive crisis as well as the status of the other organ. What has happened? What is and there is any damage of any organ damage presence or not. So complete blood count and blood smear apart from the renal function test and electrolyte level, hypokalemia and other electrolyte disbalance may give a clue to secondary cause of hypertension. Urine analysis, as I told earlier, hematuria and proteinuria may be a suggestive of gallbladder damage. Electrocardiogram for myocardial ischemia and chronicity of the hypertension with evidence of left ventricular hypertrophy. Cardiac marker of ischemia like creatinine, kinase and troponin should be checked, but troponin is a very sensitive marker and will commonly be slightly above the upper limit of normal in severely hypertensive patients. This is a isolation should not be considered as acute end organ damage. Chest radiograph, chest X-ray, cardiomegaly, pulmonary edema, and voiding mediastinum can be seen. On CT scan and MRI of brain to evaluate any neurological deficit and altered mental status, especially in the setting of suspected primary stroke, hemorrhage, or trauma. Urinary toxicology screening should be collected because cocaine and other illicit drugs frequently cause severe hypertension. And after appropriate management and resolution of the crisis, workup of common secondary cause of hypertension should be performed, as I told. Now, management of hypertensive emergency. So, there is the presence of acute, rapidly progressing end organ damage and absolute and not the absolute blood pressure reading. As I told, there is no cutoff value for hypertensive emergency. So 130 by 80 BP can produce end organ damage, like in aortic dissection patient. So in that case, there is no 180 by 120 blood pressure criteria is maintained. So we have to come down with the BP in 130 by 80 patient with acute aortic dissection. So there is no such absolute blood pressure value is not necessary. We have to keep the absolute blood pressure in our mind. So we have to check the end organ damage presence or not. It is recommended that blood pressure reduce initially not more than 25% of MAP over minutes to hours. So first 1 hour, our target to reduce the MAP 20 by 25%, not more than that. Why? Because there is to protect the cerebral function after initial reduction of blood pressure by 20 to 25% within first hour, pressure is further reduced over next 2 to 6 hours to 160 by 110 rate as long as patient remains stable. So, what is practically the normal, as we know, the auto-regulatory system of our cerebral blood flow, cerebrovascular system belongs to around 70 to 150 millimeter of mercury. When there is a high BP, there is a rupture or there is disruption of the auto-regulatory system. So, when we calm down the BP, we need to give some time to reset this auto-regulatory mechanism. So that they can the cerebral blood flow can be preserved, because rapid decrease of the blood flow rapid decrease of blood pressure can cause decreased cerebral perfusion so rapidly that there may be some sort of problem that could lead to a altered mental status, dizziness, drowsiness, nausea, vomiting. All these symptoms can be happen. So So we have to check the we have to keep in mind that blood pressure we have to keep the map around 20 to 25% from the primary level in first 1 hour. Then next 2 to 6 hours we have to come to slowly. As in the continuous stability, the blood pressure may be then decreased to 140 by 90 millimeter of mercury over next 24 to 48 hours. With this decreased blood pressure, CSA auto-regulation is usually maintained. After the first 24 hours, further reduction should occur over days to week in order to allow auto-regulatory mechanism to reset, as I told earlier. But exception is there, like aortic dissection, post-operative bleeding, and pulmonary edema. In these cases, we need to more aggressive blood pressure reduction to prevent catastrophic complication. Now, these are the medication that used for hypertensive emergency. First of all, sodium nitroprusside. It is actually venodilator. It causes a relaxation of the smooth muscle of venues and causes vasodilation. Mainly, there is a reduction of preload. In high doses, it can cause the afterload reduction too.
No, nitroprusside is not a venodilator. Sorry, it's an arterial. You can read about nitroglycerin, but about nitroprusside. Nitroprusside is a very strong vasodilator. Very strong vasodilator. That's nitroprusside. I think we will come to that.
So its onset of action 2 to 3 minutes and initial dose 25 to 0.25 to 0.5 miles per kg per minute. Maximum dose given 2 miles per kg per minute, but practically I have seen the cardiology book, most of them they are telling up to 10 miles per kg per minute can be given. But 2 miles, more than 2 miles, there is chance of more cyanide toxicity, thiocyanide toxicity, or more when we use more than 2 miles per kg per minute. So we can indication most hypertensive emergency. Contraindication in pregnancy because it can cause placenta, so it is contraindicated in pregnancy. And also as it causes increased ICP, so there is a chance of cerebral edema, acute coronary syndrome, or azotemia. Azotemia, coronary syndrome, hepatic failure because there is chance of cyanide toxicity and thiocyanide toxicity. So all these things we have to keep in mind. Now come to nitroglycerin. So it's acted by nitrate, dilation by nitric oxide. So mechanism action, pharmacology, onset 2 to 5 minutes, duration 5 to 10 minutes, initial dose 5 miles per minute. So acute coronary syndrome is the indication because it reduces the vasospasm and distribution of coronary blood flow caused by nitroglycerin. So for particularly cardiological cases, we can use nitroglycerin for the blood pressure. Contraindication is pregnancy, caution of using volume contracted stages because there is a decrease of the preload, so further volume, there is a reduction of the blood pressure can happen. Exerted reduction of the blood pressure can happen. Now, nicardipine and cilnidipine both are dihydropyridine group of the calcium channel blocker. It can give a hypertensive patient, but both cases can replace tachycardia and can cause a problem. Particularly cilnidipine, there is a contraindicated with allergic to soybean or egg product as it is given in emulsion form. Now, labetalol, it is both beta blocker and alpha blocker, but beta blocking action are more pronounced than alpha blocking action, around 7:1. So, onset of action 2 to 5 minutes and duration 2 to 4 hours. Given usually initial IV bolus 20 milligram, we can repeat every 10 minutes by 20 to 80 milligram in 6-hour day. Infusion 1 to 2 milligram per minute. It can be given in most hypertensive patients, but contraindication is airflow obstruction, acute heart failure, and patient with non-tolerant to beta blocker, as because of it is non-specific beta blocker. Now come to phentolamine. Phentolamine is a dopamine 1 receptor agonist, and it causes use for pheochromocytoma or catecholamine withdrawal, catecholamine except this kind of patient like monadil withdrawal patient, MAO inhibitor patient, we can give phentolamine for treatment of hypertension. Now enalapril is AC inhibitor. It is used for scleroderma crisis patient, but it can the action is unpredictable action. Hydralazine mainly arterial dilator, and the onset 10 to 20 minutes and duration 2 to 4 hours. So it is indication mainly in pregnancy, in eclampsia and pre-eclampsia patients. Now hypertensive encephalopathy, this is a condition when cerebral edema is induced by mildly elevated blood pressure because of disarrangement of the autoregulatory system of the brain. So it can lead to cerebral edema. Features of cerebral edema will be there, like irritability, headache, altered sense of consciousness, these things. The treatment of choice is sodium nitroprusside or labetalol. So sodium nitroprusside theoretically can cause increased ICP, but practically it has not been seen. So sodium nitroprusside can be used in hypertensive hemoglobinopathy. If there is no improvement despite of the appropriate decrease in the blood pressure, the diagnosis must be reconsidered and concern should be for a primary neurological insult causing secondary hypertension. Now this is the BP target in cerebral vascular accident. It's more or less we know. In subarachnoid hemorrhage, you have to target BP around systolic blood pressure must be kept around less than 140 to 160. And if associated with a high ICP, we have to keep MAB more than 80 to maintain the cerebral blood flow. Similarly, intracranial hemorrhage, we have to keep the BP around 140 to 160. In acute ischemic stroke, before thrombolysis, we have to keep the SBP 185 to 110. For 24 hours after thrombolysis, 180 to 105, because high BP increase the risk of post-thrombolysis hemorrhagic conversion. And acute ischemic stroke where thrombolysis is not possible, then we have to keep the BP around 220, 120. We have to BP only when it crosses on 220 by 180. To decrease BP by 15% over 24 hours is recommended if BP more than 220 by 180, because to maintain the blood flow in brain.
We don't need to maintain this, we accept this pressure.
Yes. Now comes to acute aortic dissection. So aortic dissection is the actually features of intimal layer, tear of the intimal layer, and blood come from come into the tunica, medial layer of the aorta. So and leads to aortic dissection. So there is a two lumen formation. One is true lumen, and one is false lumen. False lumen between media and intima, and true lumen below the intima. So blood pressure must be corrected immediately in case of acute aortic dissection, because there is a high mortality in case of acute aortic dissection. Patients with a type 1 dissection have a mortality rate of 1% per hour in the first 48 hours unless medical therapy is instituted rapidly and the patient referred for emergency surgical intervention. So main treatment for type A aortic dissection is surgery, but we have to start medical therapy as early as possible. Target MAB is around 100 to 110 systolic blood pressure. In the setting of uncomplicated type B dissection, anti-hypertensive therapy is the main treatment aimed at the reducing vascular resistance and shear force on the vessels for the treatment of the choice. This should be accompanied by the beta blocker prior to vasodilation in order to prevent reflex tachycardia. So, systolic blood pressure between 100 to 110 with a heart rate between 50 to 60 per minute is goal. So, aortic dissection, as I highlighted, tear in the intimal layer, and there is two types as per Sanford classification, type A and type B. Type A when ascending aorta is involved, that is called type A. In case of type B, it is when the descending aorta is involved, that is come to type B. Now, acute cardiogenic pulmonary edema. In this case, sodium nitroprusside or nitroglycerin is the treatment of choice. So, better to avoid the loop diuretics because they may have an initial beneficial vasodilatory effect, but subsequent volume depletion can cause further hemodynamic side effects in later. Because the pulmonary edema is due to maldistribution of intravascular volume, not due to the total volume overload. So the treatment should be aimed to decrease the acute pressure of volume of pressure overload and afterload mismatch, which will reverse the fluid shift and time frame similar to the rate of decompression. In acute cardiogenic, what is happening? This is a flash pulmonary edema. It is suddenly rise of blood pressure. So this is usually this acute cardiogenic pulmonary edema seen in the mainly group of older age group people. Those usually chronic hypertensive patient, and there is some sort of diastolic dysfunction is there. So if there is a sudden rise of blood pressure, there is an increase afterload of left ventricle. So it causes the increase the end diastolic volume will be more, and will ultimately transfer the pressure to the pulmonary vein to pulmonary capillary. So there is a transcapillary leakage. So and leads to cardiogenic pulmonary edema. So it's not the volume overload, total volume overload per se, but the increased afterload and the mismatch between afterload and pressure overload causes the transpulmonary leakage and leads to pulmonary cardiogenic pulmonary edema. So in these cases, loop diuretics may not be that much effective, particularly if patient is euvolemic prior. So after giving the loop diuretics, there may be chance of hypovolemia and there is hemodynamic instability later on. So preferred drug is sodium nitroprusside or nitroglycerin. Now come to cardiac system. Myocardial infarction, elevated blood pressure can induce ischemia from the increased oxygen demand. In addition, high blood pressure can rupture the stable coronary plaques, resulting myocardial infarction. So blood pressure reduction with nitroglycerin is the treatment of choice. Nitroprusside is added if further blood pressure reduction is required. Heparin infusion should not be started with uncontrolled systemic blood pressure when it is more than 190 or above, because the risk of intracerebral bleeding is significant. Now, post-operative bleeding. This is the thing we have to reduce rapid decrease of the blood pressure, whatever the situation is. So, bleeding from vasculature suture line should be treated with immediate normalization of blood pressure, similar to an aortic dissection. So, parenteral treatment with sodium nitroprusside, nicardipine, or labetalol is preferred. After coronary CABG, the nitroglycerin is considered the initial drug of choice to maximize the cardiac perfusion. Preeclampsia, so it is the delivery of the fetus and placenta is the treatment of choice, particularly in case of eclampsia. Intravenous magnesium therapy is the treatment of choice for the prevent progression to eclampsia. Labetalol and hydrolizin is the drug which can use for can be given safely in pregnancy, but ACE inhibitor and ARBs is contraindicated in pregnancy. Phentolamine is the treatment of choice for treatment of catecholamine excess status. So intravenous alpha blocker, which is phentolamine, is effective for catecholamine excess. Beta blocker should never be used in isolation because they can cause paradoxical increase in blood pressure because of unopposed alpha receptor action.
So it's basically এখানে বলছো যে আলফা ব্লকার প্লাস ফরওয়ার্ড বাই বিটা ব্লকার বা এরোটিক ডিসিশনের সময় বলেছো প্রথমে বিটা ব্লকার ফরওয়ার্ড বাই তাহলে নোটে দেখো অ্যাভারেজেশন
না আই মেনশন ফার্স্ট সেকেন্ড না আমি যে দুটো ইউজ করতে পারি মানে
I have this should be accomplished via beta blocker prior to vasodilatation. You have to even replace that idea. Beta blocker first, if required, alpha blocker. You have target beta blocker. Decision followed by second blocker replace the alpha blocker.
Currently, as I told, there is a high BP without end organ damage. So, but we lower initial doses of antihypertensive medication are used to treat the patient with a known cerebrovascular disease or coronary artery disease or with volume depleted patient. These patients tend to have exaggerated response to drug therapy. Monitoring for 4 to 6 hours is necessary to judge treatment effect and look for complications. Urgent follow-up care is mandatory within 24 to 48 hours. Patient with specific optimal blood pressure control can achieve over next 2 to 3 months. So, hypertensive emergency, we may not need to admit the patient in hospital, but need to follow up for 4 to 6 hours and after 24 to 48 hours. So, we can treat it in OPD basis and with oral medication.